left the briefing book upstairs, so anyway. I now call to order the hearing on the fiscal year 2023 President's Budget for the National Institutes of Health. This is a hybrid hearing, so we need to address a few housekeeping matters. Now, welcome my colleagues who are with us on the screen. For the members joining virtually, once you start speaking, there is a slight delay before you are displayed on the main screen. Speaking into the microphone activates the camera, displaying the speaker on the main screen, so do not stop your remarks if you do not immediately see the screen switch. If the screen does not change after several seconds, please make sure that you are not muted. To minimize background noise and ensure the correct speaker is being displayed, we ask that you remain on mute unless you have sought recognition. The chair or an individual designated by the chair may mute participants' microphones when they are not under recognition to eliminate inadvertent background noise. Members who are virtual are responsible for muting and unmuting themselves. Finally, House rules require me to remind you that we have set up an email address to which members can send anything they wish to submit in writing at any of our hearings. That email address has been provided in advance to your staff. With that, what I'd like to do is to acknowledge and thank Ranking Member Tom Cole and all of the members of the subcommittee joining today's hearing, both virtually and in person. And a thank you to our witnesses testifying before us today. Dr. Tabak, welcome to the subcommittee. While you started in this role just a few short months ago, you have proven in your over 12 years as a Principal Deputy Director of the National Institutes of Health and 10 years as a Director of the National Institute of Dental and Craniofacial Research to be a thoughtful, efficient leader. Thank you for your commitment to making America a healthier place and our health care research more equitable. Our deep thanks. Let me also welcome Institute directors joining Dr. Tabak today and our subcommittee this morning. Dr. Diana Bianchi, Director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development. Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases. Dr. Gary Gibbons, Director of the Heart, Lung, and Blood Institute. Dr. Douglas Lowy, Director of the National Cancer Institute. And Dr. Nora Volko, Director of the National Institute on Drug Abuse. I also want to note, and I think I've said this before, we were able to do it once before, that I do intend to invite an additional panel of institute and center directors to testify before this committee later this year. We have not been able to hold a second panel in the past 2 years, but I value the research of every institute, every center, and want to make sure that the subcommittee has the opportunity to hear from others directly. I'm also going to be reviewing the funding across all the institutes and centers for looking for patterns over time and to hear more about how the institutes and the centers set priorities. And I just say this with all sincerity. I mean, I also always think that this is one of the most exciting and exhilarating and meaningful hearings that we have before the Appropriations Committee. The work that you do, all of the staff, the grantees that the NIH supports, and what you have done to continue prioritizing COVID-19 research over the past 2 years, we would be nowhere close to where we are in defeating this virus. Through the research of the NIH own scientists, and everyone talks about you know, how quickly we moved and how successful we were in terms of a vaccine. It just didn't happen overnight. It was the years of research, of investment in the research that allowed us to move as quickly as we were able to. So through the research of our scientists, researchers, grant institutions, and partnerships with the private sector, our knowledge of the virus has dramatically improved. Reliable detection and diagnostic technologies have been developed, treatment options have been implemented, and vaccines and other prevention methods were accelerated and distributed, all in record time. NIH's response to COVID proved what I have known for a long time, that our significant and longstanding support for biomedical research is absolutely critical to ensuring we are prepared to prevent and address healthcare crises whenever they may arise. The work you do saves lives and protects families the world over. And with the proper resources and leadership at NIH, our biomedical research can move very quickly, very focused ways to achieve high-priority goals and continue to save lives. None of these transformational advances would have been possible without the annual sustained investments in basic biomedical research made by this committee in a bipartisan way in recent years, which is why I am so proud that over the past 7 years, Congress has increased NIH funding by nearly $15 billion, or 49%. And I repeat that this has been done in a bipartisan, with a bipartisan effort. And in the 2022 omnibus recently passed, Congress provided a $2.25 billion increase over 2021. This includes an increase of $353 million to fund a greater number of research proposals at the National Cancer Institute and support for the Cancer Moonshot Initiative that will save lives by speeding cancer research progress and improving prevention, detection, and treatment efforts. We also provided an increase of $289 million for Alzheimer's disease and related dementias research to help us better understand the cause of Alzheimer's and advanced research for diagnosis, care, treatments, and prevention for those with and at risk of developing this disease. I'm especially proud of the $30 million increase for the Improved Maternal Health Research Initiative. The maternal mortality rate in this nation is far too high, the highest of any developed nation. And more must be done to address this crisis that kills hundreds of mothers every year. These increased funds to support research on maternal morbidity and mortality will reduce preventable causes of maternal deaths, improve the health of pregnant people, especially those mothers, the victims to our nation's health disparities who have been historically underserved. And health disparities impacting underrepresented communities are an unacceptable issue in nearly every corner of our physical and mental health care system, which is why we delivered an increase of $50 million for research to identify and reduce health disparities across our country. I'm also proud of the $8 million increase that Congress provided for the Office of Women's Health, research on women's health, to further promote the interests and involvement of women in NIH-supported research. And I am personally grateful for the $159.4 million in fiscal year 22, the NIH grants that have been delivered. Many have been delivered to my own district, Connecticut's third, following $572.8 million in fiscal year 2021. That's NIH funding for the district. This funding has already advanced critical research efforts, strengthened the future economy, and grown opportunities in my community. But my hope is that this is replicated in cities and in small towns and in rural areas across the country. We have to move it beyond large cities, areas, into the across our country. As we continue to build on these transformative investments, I'm pleased that the President's budget request for 2023 proposes an increase of nearly $4.3 billion for NIH. I'm pleased that included in the budget request is a proposal to increase research to address health disparities and the opioid crisis, two major issues impacting the health of far too many across the nation. Particularly glad to see the proposed $15 million increase for universal flu vaccine research and development, an issue that I have been fighting to address for years. And the request would double funding for gun violence prevention research at the NIH, building off the investments this subcommittee has made over the past 3 years. Despite all the great investments in the bill, however, I am concerned about the lack of balance between the budget request for ARPA-H and the request for other more, quote, traditional NIH activities. I know the President's fiscal year 2023 budget request for NIH was developed before the 2022 omnibus was enacted and might have been different had it been enacted sooner. However, the proposed increase, $274 million for core NIH activities, is insufficient and threatens the progress this committee has made in the past several years through significant, sustained investments in biomedical research. I've said it before, and I will repeat it. I am proud of the work we have done together to establish ARPA-H. It is clear that the $1 billion investment in 2022 funding this committee made to establish ARPA-H has the incredible potential to develop transformative technologies that save lives. It's historic funding, and it will be used to research the causes and address debilitating impact of major diseases like Alzheimer's, diabetes, cancer, ALS, and others that impact the lives of millions of Americans and exacerbate already existing health disparities. However, it is critical that we strike a balance between the investments that we make in ARPA-H and those in basic research and discovery at the NIH. Dr. Tabak, I know this was not your decision, but while I strongly support NIH and recognize its long record of success in supporting biomedical research, I believe that placing ARPA-H within NIH is a mistake and will hamper the agency's ability to achieve the breakthroughs I just outlined. I strongly believe that ARPA-H would be more successful in its unique mission if it were established as an independent agency within Health and Human Services. With that, let me just say I thank you all for joining us today. Your work, again, is invaluable to the health infrastructure of our nation, to really improving our medical discoveries, for making these medical discoveries, and ultimately saving lives. I look forward to our discussion this morning and our work together in the months to come. And let me recognize Congressman Cole for his opening remarks.
Thank you very much. Before I begin my prepared remarks, I draw one great lesson as a proud Yale graduate. It's a great thing to represent Yale. What a great magnet for research and good things. Well, good morning. I'm pleased we can come together in person this morning for the first time in 2 years to hear directly from the National Institutes of Health about the administration's budget proposal for fiscal year 2023. This is our first hearing in many years without our friend Francis Collins, and we all wish him well in his new endeavors. As I say every year, a sustained commitment to increasing funding for the NIH is a vital step to preserving our status as the world's leader in biomedical research and to finding cures for many diseases burdening our healthcare system. And we know the funding also does far more. Several studies have shown funding at the NIH has a multiplier effect, contributing to overall U.S. economic growth. Like the chairman, I'm proud of what this committee has done year after year on a bipartisan basis since 2015. The NIH budget has increased every year beyond inflation during that period, regardless of who was president, regardless of which party was in control of the Congress. And it shows that there's certainly some important things that we can work together on, and I think will have positive results for the country. And I particularly want to praise my good friend. I make this point a lot, the chairwoman. When I was privileged to be the chair of this subcommittee for 4 years, she was kind enough to back my budget, not the first one, but the last one, the one that passed, every single time. And I've been very proud to vote for her budget for 3 terms since then. So we may start in different places, but we have a way of ending up at the same place. And this agency, the NIH, is a big reason why, quite frankly. So you actually contribute to bipartisan comedy and cooperation. Given all that, I hate to kick off the hearing on a sour note, but I'm probably where the chairwoman is. That I'm perplexed as to why the administration has chosen to pour billions of dollars in funding into the new ARPA-H program at the expense of ongoing basic research at the NIH. ARPA-H was funded for the first time in March. And I might add, with my support, like the chairwoman, I see much potential good here. But as she pointed out in her remarks, there's still a great deal of controversy around it and different opinions from both Republicans and Democrats, and quite frankly, within their ranks over how it should be organized, where it should be placed. In the end, almost every decision was simply left to the Secretary of Health and Human Services, someone I hold in high regard, but he's an executive official. And I think it's unprecedented for the creation of a new agency to lie largely in the hands of one individual. We still don't know the structure of this new the structure this new agency will ultimately take. We don't have a director, any possible names of a director, or any idea when this individual will be named. We don't have a physical location for the new agency. We don't know how grants will be made and who will be responsible for deciding how billions of tax dollars are dispersed. We don't know how ARPA-H will interface with existing NIH institutes and research, or how we can ensure that it will be value added rather than an agency that competes with and siphons off talent. We don't know the rules for hiring staff or how they will be compensated. So I think it makes no sense to propose an enormous increase of $4 billion for this new agency while proposing what is essentially flat funding and for some important agencies, even a modest cut for the rest of NIH. And I'll have some tough questions about that today, but it sounds to me like we probably have some of the same concerns, Madam Chair. Next, I think everyone in this room needs to address the difficult topic of the loss of public confidence and credibility across our public health agencies, including the NIH, during the COVID pandemic. I fear that the mistrust in our government public health system has eroded to a dangerous level. From our own leaders placing too much trust in the Chinese government in the beginning of the pandemic, to locking down our society, economy, and schools, from mixed messages on masking and vaccine mandates, to what many believe is a cover-up on the role, if any, that the Wuhan lab played in the origins of COVID virus. Our public health agencies have made mistakes that need to be acknowledged and corrected. This has weakened confidence in our public health and government systems for many of our constituents at a time when we desperately need to come together as a people and heal. I certainly pledge to work with my friends across the aisle to rebuild a bipartisan coalition of support for basic science and research, and talk honestly about ways we can translate that information into evidence-based practices using data, not just talking points. Most of our constituents want to do the right thing to stop the spread of COVID. Many just don't believe what they're being told by government officials anymore, and I suspect we'll hear some difficult questions about that this morning. Much attention in the past year has gone to COVID, and rightly so. But I hope we can also continue our conversations and scientific advancements in such areas as cancer treatment and dealing with Alzheimer's, diabetes, other dread diseases and chronic illnesses. These diseases are responsible for the loss of hundreds of thousands of American lives every year. And again, I fear this work may be shortchanged by the hyper-focus on the new ARPA-H, and I sincerely hope that will not come to pass. We have an excellent team representing some of the largest institutes and most promising frontiers of new discoveries before us today. As we know, NIH is composed of 27 institutes and centers, most of whose leaders are not able to be with us today. But even though we're not able to have each director come before us, our offices continually learn about the groundbreaking work and collaborative partnerships at all of the NIH components. And we're all very proud of that work and know our role in making sure that it goes forward. We know that the work done at NIH and each institute or center is a contributor. In closing, I want to stress that each dollar invested in the NIH is, in my view, a down payment on our future. This work has in the past and in the course and will change in the course of disease detection, cures, and the years and generations to come. I know Congress's commitment to advancing these shared objectives is unwavering and bipartisan. I want to thank you, Madam Chair, for holding the hearing and thank our witnesses for being here. I yield back.
Thank the ranking member. And Dr. Tabak, your full written testimony will be entered into the record. And now you are recognized for 5 minutes for your opening statement. Thank you.
Thank you, Chair DeLauro, Ranking Member Cole, and distinguished subcommittee members. I'm honored to be here today with my colleagues representing the National Institutes of Health. This is a time for NIH and the entire biomedical research community to re-examine all of our efforts. During the COVID pandemic, we were driven by the urgency of the moment. NIH must learn from this experience and seize the opportunity to define a new normal. As acting director, I am committed to new strategies, new voices, and a renewed focus on the future. Now is the time to reflect on what worked and did not work to address COVID and to shape new strategies. Your sustained investment in NIH research set the stage for the new mRNA technology and immunogen design that were key to the development of safe and effective vaccines in an unprecedented timeline. Since these vaccines became available, it's estimated that more than 2 million American lives were saved and more than 17 million hospitalizations were averted. Now we need continued support for a wide range of biomedical fields, including behavioral and social sciences, to identify and successfully implement better ways of responding to the short and long-term health effects of COVID-19, to prepare for future pandemics, and to ensure equitable protection of our diverse population. And it's not just about vaccines. Our Rapid Acceleration of Diagnostics, or RADx initiative, fueled the development of many new approaches for COVID-19 testing that are already being used in our communities. To help ensure that such benefit was shared with those disproportionately affected by the pandemic, we initiated efforts like RADx Underserved Populations and the NIH Community Engagement Alliance. These experiences, along with other NIH-led efforts focused on COVID treatment development, demonstrate the extraordinary value of public-private partnerships. The NIH can build upon the momentum of the COVID response and apply it to other challenges through the Advanced Research Projects Agency for Health, or ARPA-H. Thanks to your inclusion of key authorities and funding in the omnibus, NIH is beginning to frame the basic administrative infrastructure for ARPA-H. This is a first key step in creating a permanent home for the strategic partnerships that are so urgently needed to address cancer, diabetes, Alzheimer's, and many other diseases. But we can't stop there. In addition to new strategies, biomedical research needs new voices. A growing body of evidence demonstrates that inclusion of diverse perspectives yields better outcomes. In the clinical setting, diverse medical teams provide more accurate diagnoses and improved health for patients while building trust. We do better science when we have a diversity of scientists from different backgrounds and communities, scientific fields, and various career stages. NIH continues to prioritize, fund, and empower early-stage investigators so that they can succeed as independent researchers. In 2021, we reached an all-time high of early-stage investigators funded, 1,513. The passion and commitment of our scientists is matched by the voices of people living with a wide range of diseases and conditions. Conversations with patients and their advocates are sometimes difficult, but those are often the discussions that teach us the most. From the AIDS advocacy groups of the 1980s to today's groups for autism, ME/CFS, long COVID, and many others, these voices have refused to be ignored, and ultimately, all of us benefit. This is a moment for renewed focus on the future. I spend a lot of time encouraging early-stage scientists, but I also think about the importance of engaging elementary school-age children like those my wife has taught for over 40 years. During the COVID pandemic, exposure to the importance of science has been a big part of many of their lives. Past pandemics have inspired young people to become scientists, but the images they saw were usually of older men who looked pretty much like me. Hopefully, today's kids are seeing more scientists who look like them. Still, we need to do better. Our nation needs all the bright minds we can find, and I hope you will continue to work with NIH to make this happen. Thank you for your time, and I welcome your questions.
Thank you very much, Dr. Tabak. I'm going to try to get in two questions in this first round. Mentioned the subcommittee has increased the budget by roughly $15 billion over the past several years. It's almost 50%. What I'd like to do is to just have you talk about how the NIH determines research priorities. In many years, NIH proposes to increase funding for a small number of initiatives: Brain Initiative, Precision Medicine Initiative. This year, significant increase for ARPA-H. In fact, the proposed increase is significantly larger than the increase for the entirety of NIH research combined. My question is, what are the determining factors in setting NIH research priorities? Is there such an emphasis on large-scale initiatives? If there is, what is being left behind? What happens to research in important areas of health that are not included in large-scale initiatives or ARPA-H? And how do we determine progress in these initiatives?
Well, as you know, it's a balance that needs to be struck. And in recent years, there has been an emphasis on large-scale investment because the scientific opportunity presented itself, either due to new technologies or emerging areas of concern. But in each instance, institutes and centers try and prioritize their effort based upon whether the science is ready to move forward, what the public health need is, and then whether or not the portfolio that they currently sustain is sufficient to move the field forward. Each institute and center has a strategic plan, and they work with closely their National Advisory Council to make sure that work that is supported aligns with those strategic plans.
I want to get on to my next question, but a concern is, you know, what do we believe these days is being left behind and that are not included in the large-scale initiatives?
Well, our success rate overall is roughly 20%. And I think historically we have observed that meritorious applications come at least through the top 1/3. So the difference between the 20% and the 33% represents what's being left behind, as you put it. Those are studies that are certainly worthy of support, but obviously with finite resources, prioritization has to be made.
Okay. Let me just ask you, you mentioned success rate. So the success rate for NIH research grants increased each year from 17% in 2013 to 20.6% in 2020. However, despite a funding increase of $1.3 billion in 2021, the success rate actually declined to about 19%. I know there are several factors that are at play here, but why did the success rate decline despite the funding increase in 2021? And what is NIH doing in 2022 to avoid another year of decline in the success rate?
So as you know, the success rate is simply the number of applications that are funded divided by the number of applications that we receive. And in fiscal year 21, we received an unprecedented number of applications. And this increase is largely what drove the modest decrease in the success rate. Obviously, we can't control the number of applications that we receive. And as you alluded to, there are other factors, but the main driver for this decrease was the unprecedented increase in new applications.
Thank you. I'm going to, I've got a few seconds left here. I'm going to yield back. And also to mention that I have to step out because there are 2 other hearings that I have to just pop into, and then I will be back, and I'll ask Congresswoman Roybal Allard to take the chair. And with that, Congressman Cole.
Thank you very much, Madam Chair. We really don't coordinate our questions, but they're pretty close some days. I want to go back to this concern I think the chair and I both have about the disparate or the imbalances, we would both see it, or I don't presume to speak for her as I see it, between ARPA-H and NIH. And I suppose my first, and again, I want to stress, Dr. Tabak, I recognize you don't get to make all these decisions either. And I suspect, honestly, we're speaking for more of you than any of you could admit. But I don't want to throw out the baby with the bathwater. And to me here, the basic mission of NIH, which I think you all have done a remarkable job in advancing over the years, is the most important element. And ARPA-H, I hope over time will develop into something like DARPA, but we just simply don't know that yet. So tell me what would happen with $4 billion when we don't know the director, we don't know the procedures, and you can't possibly have that set up, to be fair to you, because you didn't even know how much money or this thing was going to even exist until March. So we just sort of threw this at you with $1 billion and say, come back and show us something. I don't think we can probably afford to follow that with $4 billion more, particularly if we pinch the budgets of the other institutes. So again, tell me what that $4 billion would do.
Well, our first step, of course, is going to be to build out the infrastructure, the administrative infrastructure of the organization. And from the practical standpoint, with the new organization within NIH, we can draw upon some equities that are standard, that are used by across HHS and indeed from other departments, things like our electronic ERA system for grants following and tracking and so forth. Search is underway for the inaugural director for ARPA-H. And as you know, this is a presidential appointee. And our charge at the moment is to really focus on the administrative issues. We will certainly bring in a small group of senior operational people focused on the administrative side, but no program managers who will be driving the science will be recruited until the director is in place.
Well, again, I want to switch to another area, but that would suggest to me that we should be very cautious here about this amount of money. Again, because I just think it's going to take a while to set this up, get it right, and frankly, I'm not convinced the other committees in Congress, Energy and Commerce is going to want to have something to say about this. They're not going to just let the Appropriations Committee create this out of whole cloth. So that again just makes me very uncomfortable on bouncing. Although let me make this very clear too. I totally favor the amount of money we're talking about. I don't have any problem with that. I just have a problem with the distribution between NIH and ARPA-H, given how formed and successful one is and the other's in the process of being formed. Dr. Loy, it's good to have you back, and I want to go to this question quickly that the chair touched on, because I think probably in cancer we're seeing one of the most difficult jobs is just the sheer number of applications that are quality applications you're getting. So what's the funding rate at NCI for applications as compared to NIH district-wide, and how promising is the science in cancer going forward?
Well, thank you, Mr. Cole. The funding rate at the NCI currently is 11% pay line for experienced investigators and 16% for early stage investigators. Last year, thanks to the generosity of Congress, we were able to give more awards than we have ever given before. Actually gone up by about 25% for experienced investigators over the last 4 years and about 60% for early stage investigators. But as you know, there's been a big increase in the number of applications to NCI, substantially larger than the rest of the NIH. This is very good news in the sense that it's a reflection of the optimism that people have of being able to make progress in cancer. But a direct consequence is that there is a decrease in the pay line and success rate.
Well, my time's up, but to me, again, you've just made the point as to why we need to get more resources in the various agencies, yours in particular, but I would say this across the board. We've got a lot of promising research here, and I don't want to tie up money as we create a new agency when you've got worthy recipients right now that could make immediate contributions to the mission that you have there. So anyway, I'm sure we'll be having pretty robust discussions on that. I yield back, Madam Chair.
Okay. Thank you. Dr. Tabak, I'd like to ask about the chimpanzee retirement to sanctuary. In 2000, Congress signed the Chimpanzee Health Involvement Maintenance and Protection Act into law, instituting a national sanctuary system to resettle the chimpanzees that are no longer needed in research by federal agencies. Since November 2015, when NIH announced it would no longer support any biomedical research on chimpanzees, it has been a priority of mine to see these primates retired swiftly and successfully to the federal sanctuary, Chimp Haven. However, in 2019, despite congressional directives and strong humane organization recommendations, NIH made the unilateral decision to keep the remaining 44 chimpanzees at the Alamogordo Primate Facility, which is run by the Charles River Research Laboratories, a global corporation whose business model is to breed, import, sell, and experiment on non-human primates and other animals. Since that time, 12 chimpanzees have died and at least half were euthanized. Multiple animal welfare experts have expressed concerns that Charles River management strategies may expose chimpanzees to an environment which results in chimpanzees meeting some criteria which leads to a euthanasia decision. Because invasive research on chimps was still legal when the Chimp Act was passed, Congress recognized chimps being retired would likely be older or have serious health conditions because they would no longer be useful for research. In fact, NIH's own regulations recognize the possibility that chimps with infectious disease and other health conditions will survive at sanctuary, and NIH has been moving chimps from chronic health conditions to Chimp Haven for years. Do you believe a laboratory facility managed by Charles River Laboratories can meet the physical and psychological needs of chimpanzees previously used in biomedical experiments better than a sanctuary created and designed specifically to meet the needs of chimpanzees retired from research?
It's a balance between the facility that the chimp is currently housed in versus their physical condition, their medical condition, if you will. And it is the opinion of a panel of veterinarians from NIH and from Chimp Haven and from the facility, in this case, Alamogordo, that a certain number of chimpanzees are just too frail to be moved safely. There is also some consideration for several of the chimps who are part of a social network that they should remain for that purpose as well. So when you balance those two things, that's why there are some chimps remaining at that facility.
Well, Mr. Tabak, with all due respect, they appear to be dying or being euthanized at a much higher rate than would be expected if they were in sanctuary. And the Humane Society has filed a lawsuit to force the transfer of the remaining chimps. And both the Humane Society and Animal Protection New Mexico chimp experts have reviewed the chimp health records and strongly believe that the chimps could survive transfer and would have a much better quality of remaining life at Chimp Haven. So I guess there is disagreement on that, but I'm very much concerned by the fact that the record of euthanasia and the fact that so many have already died, I think does not uphold the recommendation of NIH. And I hope that you will look at that more carefully, because my concern is I don't know what directive Congress could give that will make the NIH actually stop the current violation of the Chimp Act and move the Alamogordo chimpanzees to Chimp Haven. I don't know what it would take to do that, and I won't expect you to answer that question, but I certainly hope that you will take that into consideration. I have one question, but I am running out of time, so I will yield to Mr. Harris.
Thank you very much, and good to see you all again here. Dr. Fauci, I'm going to ask you a question. You know, last week the White House warned us that there may be 100 million cases, COVID cases this fall because of waning immunity and other things. We don't know what variant it's going to be. Depending on the variant, you know, 1 in 20 could end up on a ventilator. Of those, it could be up to 40% actually die. And we all know people who've died for COVID. It's usually people who end up on a ventilator and have untreatable lung disease. Now, you briefed us last year about the ACTIV-3 trial, which is Viptidil and remdesivir, because it doesn't appear that remdesivir does anything in those late-stage patients, Viptidil may be the last remaining therapy that we may have. And, you know, I and other physician members of Congress actually have experience with some constituents who have recovered under the drug under right to try. That, of course, is anecdotal. We do need more evidence than that. The NIH is commended to be taking on the risk of, you know, studying this medicine from a small drug company. It's a very small company makes it, because nobody could have predicted that this was kind of the last drug standing for late-stage COVID. But we're out of time now. I mean, the bottom line is, if we're going to have a surge in the fall, and right now we have no late-stage therapeutic for the person who's failed all other therapy on a ventilator in the ICU, BARDA is going to need months to ramp up production of a therapeutic. So the question is, you know, the problem right now is because the enrollment has slowed down in ACTIV-3, and I'm sure you're aware of that, because there just aren't that many people with Omicron who proceed to that level. The question is, are your statisticians going to take an early look at that data to see if a Viptidil works or works adequately enough to authorize it, scale it up so that in this fall, when we have this potential surge, we will have a late-stage therapeutic, because we desperately need one. I mean, we still don't have something for those patients, and it's terrible. You know, you go to the ICU, you get put on, you fail remdesivir, there's nothing left. I mean, you call the family in for a meeting. Can you do that? Can you look at some of the data?
Yeah. As you well know, Dr. Harris, that the company who sponsors this has the opportunity to present the data to the FDA for an application for an emergency use authorization. The NIH and our clinical trials provide all of the resources necessary to do that. So it is, with all due respect, it's not an NIH issue of whether or not this gets submitted to the FDA for an emergency use authorization.
But your DSMB is going to meet, I think, this month on this.
Right, exactly.
They could choose to take an early peek at the results.
Yes, it will. And one of the things that's very clear is that we don't interfere with the DSMB's the way they look at clinical trial data. I think that would be a conflict. So we would always welcome what they do, and if they look at the data and feel it should be an early look, then we welcome that. We have nothing against that, I promise you.
Okay, good, because, I mean, they'll never get to 650. I think that's the end number. I mean, we're just not enrolling patients anymore.
It's a good news, bad news thing.
Right, that's right. You understand it. So,
Indeed.
You know, thank you very much. Now, Dr. Tabak, I'm going to ask you something, because, you know, for years I've been holding up a graph of the young investigators' age of discovery. You're aware of this, the 2010 Jones paper, which suggests that, you know, the inventiveness kind of peaks that are in the late 30s or so. And yet I see the report from last November that looked at, from the NIH, that looked at by Dr. Lauer, that looked at the long-term trends in the age of principal investigators. You're aware of this, right? Now, you've created all kinds of committees, you've done everything, and the result is, while age has been continuously increasing in R01s, the rate of increase has slowed over the last 10 years. Well, Dr. Tabak, it's not going to continue forever. It's not going to continue to age 100. I mean, saying that, I mean, I don't get it. NIH has failed at reducing the mean age, so I'm looking at it, the mean age increased from 2015 to 2020. Whether you're male or female, the mean age increased. The NIH is failing to address this properly. What are you going to do? I mean, it's nice to say, well, we need a diversity of people, and we need people who look like, you know, a college-age graduate, but we're not funding those people. So what's the concrete plan?
So, Dr. Harris, you're correct in the data, and we're doing several things. First, unfortunately, institutions around the country increasingly want their new faculty hires to have bridge funding before they give them a permanent appointment on their faculty. And that was never an intended purpose of some of these transitional awards, but they become a surrogate for deciding who gets a tenure track position or not. So one of the things that we're doing is we've instituted what's known as the CATS Award, which is an R01 application that does not require, in fact, no preliminary data is allowed for the submission of that award. The purpose there, of course, is it frees the young person from the work that they did as a postdoc or as a graduate student and allows them to go straight away to apply. We have also done a series of mentoring networks, if you will, around the country to convince young people that that first award, that first R01, is something that they should really be striving for sooner rather than later, despite what the old sages at their institution may be telling them. Oh, you'll never get that award, it's too big, apply for a small little award. I mean, you know this well.
Been there.
And so we're trying very hard to get the word out that, in fact, we are incentivizing, we are prioritizing early stage investigators. Now, the final piece of this, and I don't have a good answer for it, is, and it doesn't account for only, it only accounts for a fraction of the time. Students enter graduate or professional school later. They take so-called gap years, 1, 2, or more years. That's something that I don't have a good solution for. But when you take all these things together, I think it has kept us sort of, you know, in stasis with regard to our ability to drive that number down. But we're going to keep working on it because it's important. I agree with you.
Thank you, Madam Chair.
Mr. Pocan.
I thank you very much to the committee and really respect and appreciate all the work that everyone at the table does, as well as many of your peers. Dr. Fauci, I just want to single you out for a second to say thank you. You know, you have been the face of everyone at this table and many other researchers, and you've taken a lot of unfair abuse thanks to fringe social media and crackpot theories out there. On behalf of normal people, to you and your family, thank you, because your family's also had to go through much of this, so appreciate it. I wanted to ask you a question. You talked at, I believe it was our WIP meeting, and you mentioned something about the number of coronaviruses we've had over several decades. And I found that very interesting because I don't think I've heard other people talk about that. What aren't we doing to address what potentially is the next, whether it be coronavirus or anything else? What do we still need to be doing and we're not doing?
Well, thank you for that question. That's very important, and it's really part of the strategy that we have already put into place, not only to address better the current outbreak of coronavirus, in this case SARS-CoV-2, but also as part of our forward-looking pandemic preparedness plan. So very briefly, what we're doing with regard to the current coronavirus is having already in place studies that have entered into preclinical and early clinical studies of what some people refer to as a pan-coronavirus vaccine, which is really very aspirational because the coronavirus phylogenetic tree is pretty big. If you focus on SARS-CoV-2, we've already had in the world 4 or 5 variants. The United States has experienced 3 of them. So the strategy is to develop a vaccine that would have not only effectiveness against all the current variants and any variant that might actually arrive out of the SARS-CoV-2 group, and then to extend that throughout the phylogenetic tree of coronavirus. So that just addresses coronavirus. But the pandemic preparedness plan is built on a concept that was developed in our group by Barney Graham, who was the person who actually developed the SARS-CoV-2 mRNA vaccine for Moderna, that to take a representative microbe from each of the multiple families that have potential pandemic capability and to do studies that would essentially position us that if we do get an outbreak from an arenavirus or an alpha virus or a flavivirus, to be able to get a vaccine into trial and ready to go within 100 days, and in the second 100 days to be able to start distributing it. So we're referring that to our prototype pandemic plan. That's what we're doing.
Great. No, it's great to hear. And again, I found that very helpful when you talked to us about it in caucus. Just a real quick, do you consider pandemics like COVID and other infectious disease like COVID a threat to national security?
Oh, there's no doubt about that. I mean, whenever you have something that threatens the economy and political stability of nations, it is part of global security. And that's the reason why we take very seriously outbreaks. And as you know, the SARS-CoV-2, COVID-19 is historic, the likes of which we haven't seen in 104 years.
Yeah, thank you. Dr. Tabak, same question. Do you consider pandemics like COVID a threat to national security?
Absolutely.
Short, sweet on that one.
Absolutely. Anything that destabilizes an economy and a nation presents that threat.
You know, it's interesting. We were talking about the $4 billion around ARPA-H and lots of conversation. And I look at the Department of Defense budget that comes in at, what, $770 billion. It's 12 times NIH. It's about 70 times the CDC budget. You know, I think it's time maybe for a more modern definition of defense, because I agree that this has been a national security threat. And since that budget seems to have such an easier time moving forward, if we could use more of those resources to protect our country, and for that matter, the globe, I think that would be helpful. I got 37 seconds. I think I can get this in. Dr. Tabak, with the global vaccine, we just talked about having the chance of having this be a broader vaccine. Will the NIH require its awardees to meet global access conditions on pricing, supplying, technology sharing for any future vaccine?
Can I turn to Dr. Fauci for that question?
Sure.
We don't have that capability of guaranteeing global access. That's part of the broader government plan, which we're trying to do right now. And as you well know, $5 billion of the $15 billion was supposed to go to global. And that global was not necessarily to get vaccine doses, because we do have enough vaccine doses for the developing world. It's to get vaccines into vaccinations, to develop the infrastructure to be able to do that. So we're very committed to that, and we have always been, but that's not within the realm of what NIH can do.
Okay, thank you. My time is up. I yield back.
Thank you. Before I yield to Mr. Fleischman, I would just say, and I was just in a hearing with Director Power at USAID, and that's, I would like at some point to really hear from all of you about what the effect of not moving forward on a COVID supplemental it will have on our ability to deal both domestically and internationally with this this pandemic. I think we're at grave risk. But that's not my question, because I want to yield to Mr. Fleischman, but I think it's an important issue, and it's one where we need your voices loud and clear about what the consequences are. Congressman Fleischman.
Thank you, Madam Chair and Ranking Member Cole. I appreciate your having this hearing today, and to each and every one of the witnesses, thank you very much. I've enjoyed my tenure on this subcommittee. I love being an appropriator, but this committee, this subcommittee is really incredible, and the depth and breadth of the NIH research is truly outstanding. So appreciate your being here today. I have two questions, if I may. As most of you know, I have substantial moral and ethical concerns surrounding fetal tissue research. The part of the debate right now is not necessarily about initial cell lines, but about the continued collection and use of aborted fetal tissue and the use of federal dollars to support that research. Much of the available fetal tissue is obtained from children killed by abortion, and their bodies are then used for experimentation at taxpayer expense. Dr. Tabak, what, if any, what is the NIH's plan for moving towards more ethical or alternatives for research and treatment, sir?
We continue to support research for alternatives in this instance. But as you know, in order to validate the alternative, you have to compare it to something. And that, in fact, is in many instances fetal tissue. But we have awarded a number of grants in this area, and we continue to make progress in that direction. But it's difficult work, and so we continue to fund that type of effort.
Yes, sir. And just for the record, I want to be clear that I can speak for myself that I would continue to wholeheartedly oppose the use of aborted fetal tissue for experimentation, and that is my personal position on that. Moving on to another topic, sir. The Undiagnosed Disease Network has been a very successful program, building on the strength of specialized knowledge at the Clinical Center in Bethesda and a network of 12 academic medical centers across the country, including the great Vanderbilt University Medical Center in my home state of Tennessee. For the past decade, UDN program has been helping patients with rare and undiagnosed conditions find answers, and for many, an informed path towards treatment. Often these families and individuals have been on a diagnostic odyssey, having seen countless medical professionals unable to give them a full picture of their rare or unknown medical condition. My question, doctor, is how does the NIH plan on supporting the network of UDN sites once the Common Fund support expires? And as a follow-up to that, how can we help develop a plan to sustain the work of UDN going forward, sir?
So as you know, programs that are initially supported by the Common Fund do graduate, if you will, out of that program. It's meant to be an incubator space. In this instance, this program has done very important and outstanding work. But you reach a point where the effort begins to blend into standard of care versus research. And so we need to define where that boundary is, and are working with the various groups around the country, as you said, to see what options we may have going forward to sustain that portion of the UDN that remains in the research space, but allow that portion which is standard of care to move into that arena.
Yes, sir. Thank you. For Dr. Fauci, good morning, sir. There's been significant debate in the scientific community regarding the risk-benefit of gain-of-function research, including unintentional lab leaks and the intentional release of pathogens into the population. My question, Dr. Fauci, considering the impact that COVID-19 pandemic has had across the world, do you advocate for a continued pause of gain-of-function research, sir?
I think it's very important, Congressman, to make sure that we abide by the set guidelines of the conduct of research. One of the problems with the word gain of function, it means so many different things to different people. So what we have done, and we're very, very flexible in re-looking at those guardrails, that when you're doing work on different pathogens, there have been a multi-year process that have set the guardrails of doing that. And those guardrails have worked really quite well. We, as everyone is obviously very sensitive to make sure that research that is conducted in a safe and effective manner, and that it is peer-reviewed before it is done by a group of people who are really qualified to make that determination.
Thank you, sir. Madam Chair, I yield back.
Thank you. Congresswoman Watson Coleman.
Thank you, Madam Chair, and thank you to the Acting Secretary. I don't know if these questions have been pursued because I was actually in another appropriations hearing, but I'm very concerned about the NIH and the investment that is made in both in diversity and inclusion, in not only the application of resources, but in the reviewers of grant applications, as well as the recipient of grant applications. We were fortunate enough to have conversations with the former director who was committed to expanding the diversity of the workforce and the diversity of the raters and the diversity of the grants that were actually funded. And so I'd like to know, kind of specifically as you can, what kind of success you've had in moving in that area.
I want to assure you and all members of the committee that I am equally committed to diversifying the biomedical research workforce. We have been using a variety of approaches to try and diversify our grantees. For example, we have developed the FIRST Award, which is designed to build communities of scientists, a recruitment of cohorts, if you will, in an effort to ensure that you have a sustainable and inclusive environment for new hires. We have also increased support for the NIMHD loan repayment program, which currently supports over 100 talented scientists each year from racial and ethnic minority backgrounds, or scientists interested in health disparities or clinical research. Several of the institutes have specific programs. For example, the NIGMS Mosaic program is specifically designed to on-ramp individuals from diverse backgrounds into positions of tenure track faculty level positions at universities.
Yes, can I interrupt? Let me ask you this. Which of these initiatives are you talking about that have just been sort of implemented in the last year and a half?
The first initiative.
Or are you talking about programs that have been in existence longer than that?
The first program that I mentioned, it's in its second year, and we're currently looking at applications for year 2. They're under review. The Mosaic program from NIGMS is new. It's within the last year.
Okay.
The loan repayment program has been used in prior years.
How about your recruitment efforts and interactions with and outreach to the HBCUs? Has anything been innovated there? Has anything been increased there?
So the most recent innovation there has been a specific outreach with our contracts organizations. Many HBCUs do not avail themselves of government research and development contracts. And we've had a specific outreach initially with 4 HBCUs, and I believe it's now up to 19, where we work together with their administrative offices to really guide them in how one goes about applying for successful R&D contracts.
So I'm really interested in what success has been built upon in terms of individuals who get to look at the grant applications and rate them, and the number of grants that are actually funded that are directed to cultural competencies and the underserved communities, Black and Brown communities in particular. And so you probably don't have time to answer that, but through my chairman, I would like to ask for kind of an update of where your agency is, where your institute is with regard to those issues, measuring from where you were to where you are now, and how you plan to move forward. And I thank you for this time, and I thank you, Madam Chairwoman. I yield back.
Ms. Herrera Butler.
Thank you, Madam Chair. You know, I wanted to ask you, Dr. Tabak, a couple of questions. And I do think, you know, in light of the chair, ranking member's comments, just overall, the NIH it's done some great things. I'm a big supporter. I think most of us have been big supporters in terms of increasing your funding because we believe in what you're doing. But it has been a little challenging in the last couple of years when there were times when I do think the image has been called into question. I'm not talking about crackpots, I'm talking about average Americans who maybe don't get to see up close and personal what's happening, and they get conflicting information. And one of the areas where I think it would be possibly helpful, I found last year, I followed some reports that genomic data, early genomic sequence from Wuhan, China, were deleted from the sequence read archive. And we worked to get to the bottom of this, and I think partially just because there were concerns, rational concerns, that the Chinese Communist Party had something to do with this, and where's the information? I wanted to see what, with regard to the sequence read archive, you're doing to secure it from those types of either truly harmful things, or maybe it's an image thing, but what are you doing in that space?
There's no question that the communication that we had about this sequence archive, sequence read archive, could have been improved. I freely admit that. If I may, the archive never deleted the sequence. It just did not make it available for interrogation.
So wait, you have the information
We
still?
have the information. We've
So it
always had
wasn't, the way it was reported is it was pulled out, the early genomic sequencing was removed by a Chinese researcher.
So anybody who submits to the sequence read archive is allowed to ask for it to be removed, and that investigator did do that, but we never erase it.
Oh, so you don't have the information anymore?
We do. We never erase the information. We keep it
So they were able to withdraw public viewing of it?
public viewing. That's correct.
Okay, so researchers can apply to the NIH and get the information from you?
And so in the way that it was originally eliminated from public view, it was withdrawn, and that's the most difficult for people to access. The error that was made, and we found this out after a review of all of our processes, was it should have been suppressed. The distinction being that if it's withdrawn, it is kept archivally on a tape drive, old technology, but that's how it's done. But when it is withdrawn, it can still be accessed by accession number, and so researchers are able to access
So the
that
information is still there?
That's correct.
That's
So
helpful.
Information was never lost.
I wanted to switch gears really quickly. I mean, I could spend a lot of time on that one, but on to overuse and opioids and overdose deaths. In Washington State, just in 2021, there was a 66% increase in drug-related overdose deaths, and more than half of these are due to fentanyl. I wanted to, your testimony talked about working on research to decrease overdose deaths. I wanted to see if you could explain how the 23 budget request is going to help you reduce that.
If I may, I'd like to turn to Dr. Volkov, please.
Sure.
Thanks very much for that question. And the budget is going to help us accelerate research in this area that is becoming very, very challenging. And it's become challenging because the complexity of overdose deaths actually has increased and made worse during the COVID pandemic. Initially, we started with research investments to improve the treatment of patients that suffer from pain so that they would not be given opioids when they didn't need it. Then it shifted to heroin, and then it shifted to synthetic opioids like fentanyl. And now fentanyl is being used to mix with cocaine, methamphetamine, and illicitly manufactured pills. So we need to diversify our scientific projects to go beyond interventions for prevention that just focus on pain. Very important, crucial, but not sufficient. We need to expand into addressing the needs and vulnerabilities of individuals that may be exposed by accident to these substances. So it goes a range of interventions, from very much implementation sciences to services research, and at the same time doing the research that can give us better medications to reverse those overdoses, because naloxone is not so effective in this new era of very powerful drugs.
That's helpful, and I will yield back. I have more questions for Dr. Bianchi if we end up doing a second round. I don't know, Madam Chair. Yield to you. Thank you.
Ms. Frankel.
Thank you, and thank you to our panel today. I got a question. I think it's for Dr. Lowy, but whoever can answer it, I'd be happy to hear from you. My question really has to do with patient navigator programs, which help low-income patients and those in underserved communities access early screening, diagnosis, and treatment. And I want specifically in terms of cancer. Can you tell me how the Cancer Moonshot program will invest in patient navigator services to ensure access to any of the new treatment?
Congresswoman, thanks for this question. Patient navigation is one of several aspects of trying to provide optimal treatment for patients with cancer, which has become much more complicated in recent years, in part because of its success. In terms of approval of patient navigation, this is beyond the NIH, but we conduct implementation research to try to optimize patient navigation, along with many other aspects of trying to help people have appropriate and full access to cancer care. This includes doing patient care at home, changing radiotherapy, for example, shortening the duration of radiotherapy, and trying to look at patient navigation in the context of this real overall issue of how to provide optimal care to virtually everyone in the United States who is unfortunate enough to develop cancer.
Well, thank you, and I hope you will work closely with whatever agency it is that directs the navigators, because obviously you could have all kinds of new developments, but if we're not able to get it, to the full population, I think we'll be missing a lot.
Thank you.
And I want to ask you, so let me ask this question in terms of research on something sort of basic. I think everybody I have ever met in my life, and you hear about this on TV, all kinds of diets, and there's fad diets, and then you read about, especially in underserved communities where people are not even getting access to the nutrition that they need. What kind of research is being done in that regard in terms of dieting and access to food for everyone?
So we have recently launched a new set of initiatives in nutrition. Among them is a study of so-called food deserts, where inadequate nutritional foods are available within a given neighborhood. And part of this research will be focused on how one can, redress that in the best way possible. Other areas of research have been powered by advances in analytical technology. Just as you have the human genome and the human proteome, you also have the human metabolome. And the metabolome is really a reflection of your nutritional state. And so we now can study things at the molecular level to give great insight into the value or not of various nutritional agents. So we are doing this from both the community-based level all the way to the molecular level.
All right. Well, at some point, I would love to just get some information on that. And then I know tomorrow we're going to be talking about, or this week, on elderly issues that affect our elderly. One is falls. But I do have a research question. The healthcare system, it's costing us over $50 billion annually on falls for older people. 36 million older adults report falls every year. I'm sure it's much more than that. We heard about technology to monitor falls in older adults and habits that can change to reduce their falls. Is there a timeline for these products? Can you explain what they are, these products to monitor falls? Is anyone on this panel aware of that?
Yeah, so through the National Institute of Aging, their SBIR small business program has made several awards. For example, they've supported a small company, Biosensics, that has developed something known as Active PERS, which is a medical alert pendant that does do automatic fall detection. And this has now been licensed and integrated into medical devices broadly, and it is available through a variety of mass market retailers. But they are supporting additional research to develop sensors, for example, that detect floor vibrations, which could be very valuable, obviously, for those who are hospitalized or otherwise infirm.
Okay, thank you, and I yield back, Madam Chair.
Mr. Molinar.
Thank you, Madam Chair. Good to see all of you today. Thank you for being with us. Dr. Tabak, I'd like to start by asking you, I know you're new in this role, but you're familiar with policies, and I noticed you have a background as in ethics, advising on ethics. And it's recently come to my attention that there is a policy at the NIH where scientists and people can receive royalties. One of the concerns I have, and I'd like you to speak to this issue, is the NIH is in the process, in the midst, as you know, of awarding grants for research, is also in the position of sort of evaluating or giving opinions on drugs that work or don't work. And the idea that scientists may be benefiting financially from the work that they've done at NIH, that creates to me the appearance of a conflict of interest. And just building on what Mr. Cole said about public confidence in the NIH, to me, one of the biggest concerns people had during this last couple years is, were they getting truthful information from their government? Could they trust what people were saying about the medicines? And to me, that creates a very disturbing appearance. And I'd like you to comment on that policy and whether you are going to take a fresh look at that policy.
The award of royalties is based on a Bayh-Dole Act, which makes no distinction as to whether or not the inventor is paid by the government, the private sector, academia, and so forth. So we are following the Bayh-Dole Act when it comes to that.
So if I understand what you're saying, so you're saying it's federal law that allows the NIH to do that?
That's correct.
Okay.
But in terms of the potential for conflict, no individual who is in a decision-making role on a particular product would have benefited from being the inventor of that product, because we separate out those functions. The individuals who make recommendations to leadership of institutes and centers are in the extramural space. The individuals who are making the discoveries that you speak to are in the intramural space. They're active scientists. And we do not allow those two things to interdigitate.
Well, but my understanding is leaders of the organization have received royalty payments. I think, Dr. Fauci, you've said that you've donated your royalties to charities, is my understanding. But what strikes me is you're in a position where you're saying certain drugs don't work, but then you can at the same time be getting royalties from other, and I understand you're saying there's a firewall, but that information has not been made public, and I think sooner rather than later, you should make that information public, because right now, I think the NIH has a credibility problem, and this only feeds into this. And I'm just learning about this. People have always, in my district, been saying, well, you know, so-and-so has a financial interest in a certain, you know, they don't like ivermectin because they aren't benefiting from that royalty, or they don't like hydroxychloroquine. Now, you may have very sound scientific reasons for either recommending a medicine or not, but the idea that people have a financial benefit from certain research that's been done and grants that were awarded, that, to me, is the height of the appearance of a conflict of interest.
Again, NIH does not, we support the science that validates whether an intervention is or is not efficacious. We don't say this is good and this is bad.
Well, truthfully, I would say you've had leaders of NIH saying certain medicines are not good.
Based upon the clinical trials that were supported by the agency.
But if the agency is awarding who the beneficiary of the grant, who's doing the trial, and there are somehow finances involved, that there's a financial benefit that could be accrued if someone's patent or invention is considered valid, do you not see that as a conflict or an appearance of a conflict of information?
I certainly can understand that it might seem as an appearance, but, and it's the sort of thing that maybe we could work together on so that we can explain to you the firewalls that we do have in place, because they are significant and substantial.
Okay, well, I would appreciate that, and I think in terms of restoring public trust, I think that would be a good next step. Thank you. I yield back, Madam Chair.
Congresswoman Bustos.
Thank you, Madam Chair. Good morning to all of our doctors here today. Appreciate you being here. Thanks for your service. I'm going to address my first question to you, Dr. Tabak. And I want to thank you for your work on biomedical workforce, and so appreciate what you're doing there. I want to start by looking at the administration's work to address inequities. So the NIH plays a leading role in advancing biomedical research, developing diagnostics, improving cures, treatments, ailments, diseases. And really the impact that NIH makes is tremendous. And, if I want to, all the stats, but I drill down to the state of Illinois where I'm from. You've got 732 awards that were given totaling $311 million, and these are in these competitive grants, so we're very pleased with that. This opportunity to use the funding to advance biomedical research is tremendous, but it also plays a meaningful role in addressing health disparities. So that's what I'd like to ask you about. I know that the NIH budget requests $350 million in increase to support research on health disparities. Can you talk, Dr. Tabak, about what broader impact that the President's budget request would have on addressing inequities that lead to disparities in access to care and patient outcomes?
It will do so in several ways. Our work in health disparities increasingly is being done at the community level. We have learned that you can't just parachute into a community, study it, and then disappear. And you have to establish meaningful trust. That takes time, but it's obviously quite worth it. And indeed, Dr. Gibbons has set up the so-called SEAL program. If I may, like him to comment on that aspect.
Please.
Sure. Thank you for that question. This is critically important. Addressing health inequities often involves what we call the social determinants of health, the fact that the context matters, the place matters. And so often, because these are such vexing problems, you need a multi-pronged, multi-level strategy that, as Dr. Tabak indicated, often begins in the community, that indeed knows its assets, knows its challenges, and even can co-develop with us strategies to address them. Certainly, we, the NHLBI, have a program related to cardiovascular health, which is clearly problematic in certain communities, low income, rural, communities of color, in which community-engaged research strategies are being shown to be effective in, for example, maintaining blood pressure control, preventing strokes, Indeed, you mentioned Illinois. We have teams in South Side of Chicago literally working on this, involving members of the community actually who have mental health issues that are intersecting with their challenges in terms of their cardiovascular risk, that holistic approach that we can take in this context. This has been borne out to be very successful in addressing the pandemic, and indeed has a broad array of capabilities for a variety of those conditions, whether it's cardiovascular disease, HIV research, maternal morbidity, mortality. These strategies we're finding to be particularly effective.
And can we drill down a little bit more too? And can you talk about the president and whoever is best to address this, the president's budget request for NIH supporting the recently announced Equity Action Plan? Would that be best for you to address, Dr. Gibbons or Dr. Tabak?
I can start. Actually, any one of my colleagues can speak to this because each institute and center is developing such a plan for their own individual organization, understanding that there is some variation among the groups. And in it, they will point out what gaps exist within their own organization, both in terms of what they do externally, but also internally. And these plans are going to be shared among all the institute and center directors so we can learn best practices. And this will be an annual event. And so they will be updated going forward.
Great. And just to play off of Dr. Gibbons a little bit about what you said, Chairwoman DeLauro and Ranking Member Cole have been great on this issue, but we actually have a Social Determinants of Health Caucus. I'm the co-chair of that. And then we have a bill called the Social Determinants Accelerator Act, where we had initially asked for $25 million that would, to your point, Dr. Gibbons, that would start at the local level to come up with plans. And then we would have this interagency council that would then help decide where these grants go. And so we got $3 million last fiscal year, $8 million this fiscal year. The president put in his budget $153 million for it. So we want, that number needs to grow. Obviously, that's the job of the appropriators and to be able to get that through. But something that I think is really the answer to having these, looking at this at a very local level, the social determinants, and helping really get health care in a better place for so many people who need us to pay attention to this. So thank you very much again to all of you. Thank you for your service to America and for trying to make people healthier. With that, Madam Chair, I yield back.
Congressman Klein.
Thank you, Madam Chair. My questions are for Dr. Fauci. Dr. Fauci, in October of 2020, Dr. Jay Bhattacharya, professor of epidemiology at Stanford, Dr. Martin Kulduff of Harvard Medical School, and Dr. Sunetra Gupta of Oxford University issued the Great Barrington Declaration. The declaration, these medical scientists argued that the appropriate strategy for coping with COVID-19 was a strong, targeted response designed to safeguard the most vulnerable populations, older persons with comorbidities, while avoiding mass lockdowns with damaging social and economic costs like the ones that we have seen, and the forced isolation of younger and healthier persons with vastly less risk of severe illness, hospitalization, and death. In response, Dr. Collins described these medical scientists as fringe scientists, and you likened their responses akin to AIDS denialism. Dr. Collins, in an October 2020 email, called for a, quote, quick and devastating published takedown of the authors in the declaration. The claim that the medical scientists opposing a strategy of comprehensive lockdowns were somehow fringe was proven to be baseless. Dr. Ioannidis, professor of the Department of Medicine at Stanford University, published a quantitative analysis of the professional publications, as well as the social media visibility of the 47 original signers of the Great Barrington Declaration in the British Medical Journal this year. He found that among the 47 original signatories of the GBD, 20, 19, and 21 respectively were among the top cited authors for career impact in their recent single year of 2019 or either. Likewise, Professor Galea and Stein of the Boston University School of Public Health cited the lack of reasoned debate over the Great Barrington Declaration as a sign of the growing intolerance of disagreement in the field of public health. So I'll ask you, on what basis did you and Dr. Collins identify these doctors, the authors of the Great Barrington Declaration, as fringe scientists out of the mainstream of epidemiological science?
I never characterized them as fringe scientists, if you look at the record. That's incorrect.
Dr.
Okay.
Collins did. You referred
Well,
to
you're asking me the question. I never called them fringe scientists.
And your comment regarding AIDS denialism?
Well, the issue with the Barrington Declaration is that what they were stating is that if you let the virus run free in society and only so-called protect the vulnerable, and the question is, who are the vulnerable in society that you are going to protect? And most public health officials totally disagree with the Barrington Declaration. And in fact, if you did that, let it just run free and not try to protect the population in general, we almost certainly would have had many more infections, many more hospitalizations, and many more deaths.
Okay.
So with all due respect to the scientists who signed the declaration, I completely disagree with them.
Okay. Would you agree that during the times of the lockdowns, the data that we have seen following these lockdowns has shown that we have had increases in depression among young people?
There's no doubt that when you
yes
put...
or no, if you could just...
I'll answer the question. There's no doubt when you put restraints on society that it causes emotional and mental stress. There's no doubt about that. But you have to have a balance of saving people's lives from getting infected and hospitalizations.
Would you agree that suicide rates have increased among young people?
Indeed, they have.
Would you agree that domestic violence rates have increased?
Yeah, well, the answer is yes, but I'm wondering what that has to do with the question you're asking me.
Would you agree that drug and alcohol use increased during these lockdowns?
Well, I'm not sure the lockdowns itself did it, and I'm wondering why you're asking me about lockdowns, because there were not complete lockdowns in this country. There were restrictions, obviously, but there were not lockdowns. China is now going into a real lockdown, so I would disagree with characterizing whatever went on in this country as a full lockdown.
All right, moving on. When the prospect of a lab leak from Wuhan gained traction in April of 2020, Dr. Collins told you that you should find some way to, quote, put down this very destructive conspiracy. We also understand that Dr. Collins emphasized that the lab leak theory could damage science and international harmony. Did you direct letters to two professional journals be written, The Lancet and Nature Medicine?
No.
You did not ask Dazik to write the letter to The Lancet?
No.
Did you review it before it was sent?
No.
All right, I yield back.
Congressman Harder.
Thank you so much, Chair DeLauro, for hosting this hearing, and thank you all to our witnesses for being here in front of the subcommittee. Since we last met, the American Lung Association released their 2022 State of the Air report. That report gave my district in California, both Stanislaus and San Joaquin counties, an F grade. This means that they received an F grade for both ozone and particulate pollution in a 24-hour period, and a failing grade for particulate pollution annually. And this has huge health impacts for my constituents. 1 in 5 kids in our community has childhood asthma. I had it, my brother had it. I know what it's like to worry whether or not your inhaler is in your backpack every day. And these F grades illustrate what everybody in our community already knows, which is our air is bad, it's only getting worse. And frankly, I refuse to let my daughter grow up breathing worse air than I did. My question's for Dr. Tabak. With this continuing trend in my community, and I believe in many parts of our country, regarding poor air quality and the staggering cases of childhood asthma, what can the NIH commit to doing with this year's budget to ensure that federal dollars are directed to programming and research to tackle the issues of air quality and asthma?
The budget does request resources to study the effect of climate on health, and certainly this is part and parcel. If I may, I'll turn to Dr. Gibbons, who is very deeply involved with this initiative.
Yes, so thank you, Representative Harder, for pointing out that very challenging situation. We've known for many years, obviously, that air pollution has an impact actually on the lung development of children, such that it stunts the development of lungs and predisposes to conditions like asthma, as you described. And we've actually seen trends over time that when the air quality improves, there is an improvement in that childhood lung function. So we know that if we can mitigate that exposure, it can have benefits. Similarly, we recognize that there are many communities, often lower income communities, communities of color, that are particularly besieged by the challenges of that particulate matter that you described. And clearly that is an exacerbant that promotes not only lung disease, but cardiovascular disease and a lot of other complications. We are making progress in terms of the family history you described with asthma. Certainly we're getting greater understanding of the inflammation, in fact, the inflammation induced by those particles on the lung. And so our treatment strategies, I think, have improved substantially as a result of basic research, in which we're understanding now the pathways and now new therapeutic targets to reduce that inflammation and enhance lung health. And so indeed, there's greater precision medicine now in how we treat asthma. But certainly, we still need to do a lot more of the root causes that relate to climate change, and the effect of wildfires and everything that's exacerbating that whole spectrum of etiology of asthma. I'll stop there.
Thank you, Dr. Gibbons. How impactful do you think those wildfires are? Obviously, this is something we're seeing all across California. How influential do you think that is in some of the asthma and air quality concerns we're seeing?
Yeah, no, it's an important observation. It clearly is contributory. We're seeing that pattern as measured in changes in those particulate matter. The air quality is deteriorating. Moreover, as you can appreciate there on the West Coast, with the prevailing winds, even those changes in wildfire and declines in air quality sweep across the country as well. And so we recognize that this is going to be a national problem, and with the trends of climate change, wildfires, and declining air quality, an ongoing problem that we hope we can potentially address the health effects through this Trans NIH program of climate change and health.
Thank you. That's very helpful. I just draw this subcommittee's attention to some of the efforts in this budget for a new community air quality monitoring and notification program, which is trying to, I believe, in essence, take some of the NIH research and make it as practical as possible. I think that's a no-brainer that we would really benefit from. So thank you so much, Dr. Gibbons. And with that, I yield back my remaining time.
Congresswoman Clark.
Thank you, Madam Chairwoman. Again, it is an absolute honor and delight to be here with so many representatives of NIH, and our deep gratitude for your science, your research, your leadership in this time of great challenge globally and certainly here in our country. I want to start with one of the increasing crises that we are seeing, and that is worsening mental and behavioral health. We are especially seeing this in our young people. And while much of the concern is focused on the limits of caring for this population, I am concerned that we need to be redoubling our commitment to better understand the issues that span neuroscience, traumatic brain injury, addiction, genetics, and more. So my question for Dr. Tabak and Dr. Valka is, how is the NIH ensuring this multifaceted topic is appropriately addressed, including coordination among multiple relevant institutes and centers? And do you have the resources necessary to meet this moment?
So we do have opportunities across NIH for the different institutes and centers in this space to collaborate with one another through, for example, the BRAIN Initiative, which is now seeking to understand the circuits of how the circuits in the brain work. But there is also emphasis on the community-based level of making sure that the appropriate mental health services are provided to those in need, as well as efforts to avoid the stigmatization that accompanies mental health conditions. But let me turn to Dr. Volkoff for her input.
Yeah, thanks very much for that question. And I think that as we're addressing all of the challenges with the COVID pandemic, we realize that when we solve the COVID pandemic, the problems that have arisen from mental health issues are going to be remaining. And particularly vulnerable are children and adolescents. And we're already seeing that with 30% increases in depression, anxiety, loneliness. We've seen an increase in suicides among teenagers, even though it's not happening in adults. And we're also seeing an increase in intentional overdoses among adolescents. And for the first time, we're seeing overdose deaths in adolescents from fentanyl. So the situation is clearly urgent. And so what we're doing is, as Dr. Tabak was saying, we're joining our efforts across the different institutes to try to understand what are the effects, how they affect ultimately the behavior of a child, what are the trajectories, and what are the interventions that we can do to support them. It's clear that it's going to have to be personalized, and it's clear, something that we have been discussing here, that the social determinants of health are crucial, and we've learned to recognize that those that are in adverse economic situations or social stressors are the most vulnerable. So understanding those factors so that we can develop interventions that can be targeted. And importantly, putting the resources that are necessary to provide those evidence-based interventions to protect children and adolescents.
Thank you so much. I want to go back to ARPA-H, and my colleague, Mr. Cole, raised a question around the National Cancer Institute, and I shared those concerns, but ARPA-H also has the potential to transform frontiers of biomedical research. I obviously think that if the decision has been made that ARPA-H should be located outside of NIH and outside of Washington, that Massachusetts, as the home of the most vibrant and promising biotech life science companies, leading edge research, academic institutions, and hospitals, is a place where ARPA-H should go. But as far as I know, there's no proposed selection process for citing this agency, and even less clarity on who will run it. Can you tell me, is there a plan on how to solicit and evaluate proposals to cite ARPA-H, and when do you expect a director to be appointed?
The search process is underway for the inaugural director of ARPA-H. This is a presidential appointment, and so obviously this is being driven by the White House. There has been no commitment made to the physical location of where ARPA-H will be located. We obviously are continuing to frame this out for the consideration of the secretary and for whoever the inaugural director may be. But until that appointment is made, no decision will be made on the physical location.
And there's no timeline for an approval process, selection?
I can tell you that the search is definitely ongoing, and I know that the intention is to move that as rapidly as possible.
Thank you. I see my time has expired. Thank you, Madam Chair.
Congresswoman Lawrence.
Thank you, Madam Chair. Doctor, I recognize that last September, the NIH announced 10 grants focused on firearm violence prevention, including one focused on firearm violence prevention tactics in K through 12. As you know, we had the last mass shooting that happened was right outside my district at a high school. And so I hope that this research is happening in Detroit, which I hope are just the first of many to address gun violence epidemic that we have. While I recognize that these awards were just made, can you speak to the importance of resuming federal research into firearm violence reduction?
Well, as you point out, 10 awards were recently made. The future research directions will likely include work to better understand the interplay of the neurological, biological, psychological, and social and structural processes that may enter into this. Also, emphasis on violence and trauma screenings and interventions need to be developed and then made available both in healthcare settings as well as school settings. And we have come to understand that the violence prevention efforts have to be multi-level and focused on mechanisms of action. So just to give you an example, there's one of the awards was made to evaluate the effectiveness of child and family traumatic stress intervention to reduce PTSS in youth after they were assaulted. It's things like this that will hopefully help us reduce and eventually eliminate these tragic events.
Well, I just want to tell you, I'm very excited about the grants, but this must become a priority for us in America. Too many moments of silence and best wishes for your family. We have to do something in America to address gun violence. In that vein, I want to commend the inclusion of more than $100 million for targeted research on mental health. We know that mental health plays a major role in gun violence and incarceration in America. And COVID-19 just added another whole level to mental health awareness and drug addiction. A lot of that is tied to mental illness. So my question is, can you highlight the impact of last year's investment on mental health research, and how does this year increase build on the NIH work from last year?
So the work that has been recently supported is really to strengthen mental health response during the time of the pandemic. It really it seeks to really increase uptake of those practices that we know that are effective. So, for example, it turns out that digital healthcare platforms are really good approaches. And we have to be able to figure out how to adapt those formats and platforms to where it is most needed. If I may, NIMH and NICHD issued a joint notice of interest that Dr. Bianchi may wish to speak to.
And Dr. Bianchi, before you speak, I just want you to know that the mental health piece and the virtual part of that was tremendous, and I hope we continue. You can go ahead.
Thank you very much for your comments. One of the things that we are very excited about is the destigmatization of youth mental health issues. And we are co-funding, along with a number of other institutes, but NIMH is the lead on this. We are funding a high school essay challenge to bring high school students in to write about their experiences, and again, with the goal of destigmatizing some of these issues. We need to bring this out in the open. There's no question that children and adolescents have been significantly affected by all kinds of issues related to the pandemic.
And also, we must look at the workforce and mental health. We know, I hear all the time that schools and other places say we don't have enough social worker or mental health professionals to address the growing demand in this crisis of mental health. Thank you, my time has expired.
Thank you. We're going to move to a second round, and we'll try to get in as many questions as we can, and we're going to allot 5 minutes per member for the second round of questioning. So with that, let me, and I'm going to try to get in 2 or 3 questions if I can. Dr. Fauci, first of all, my congratulations on being named Chief Medical Advisor to the President. I also want to ask about universal flu vaccine. Can you provide us with an update on the development of the universal flu vaccine? You're looking at $15 million in an increase. Right. What will we accomplish with those funds in with what we have there, with what's in for 2022, and the additional funds requested in 2023.
Yeah, well, thank you very much for that question, Madam Chair. Yes, the money that was given to us in the last appropriation has been very helpful, and I'll summarize briefly what has happened since we spoke last, and the additional plus up in the current 2023 budget will be very helpful. So what we have been doing over the last couple of years now has bringing a number of new concepts into the universal flu vaccine. As I mentioned to you, I think when I briefed you in a previous time, one of the approaches is to use new platforms, one of which is referred to as nanoparticle, which is a component of a vaccine that allows you to tack on to these microparticles any of a number of immunogens, as we call them. One of them is one that is very common to virtually all of the flu within a particular group of influenzas. And in preliminary studies look really very good, both in the animal model and in phase 1 studies, in which you're inducing a response that goes well beyond just the particular flu that you're vaccinating against. In addition, a number of studies, both intramurally at the NIH campus in Bethesda, as well as in our grantees, have now put into both preclinical and phase 1 study a number of candidates using these various platforms. The results look actually really very good in the sense of a vaccination now that goes well beyond the particular isolate that you're dealing with and covers. As you know, flu is divided into 2 main groups, Group 1 and Group 2, and the ones that we get exposed to, which are predominantly H1N1, H3N2, and influenza B. And the influenza A's, we now look like we can get good responses that have both depth and breadth against multiple ones within either Group 1 or Group 2. So each months and years that go by, we're getting closer and closer to what I think will be a much more effective and universal vaccine. But thank you for the support. It meant everything to get us there.
Right, and thank you. And, we'll look to the $15 million to see if we can continue that. Dr. Bianchi, just if I can, the $30 million increase to ramp up the Improve initiative. And in Dr. Tabak's testimony, he talked about establishing a maternal health research center of excellence. Can you tell us a little bit about your research to reduce rates of maternal mortality and morbidity? Are you seeing progress? How are the Centers for Excellence going to help achieve the long-term success? If you can tack onto that the $8 million that we're looking, that we did in 2022 for women's health research, and research for the Office of Research, and where that's going.
Thank you for your question, and importantly, thank you for the support for the Improve initiative, which is an NIH-wide initiative, and it's addressing many of the themes that we've heard about today in this session, particularly social determinants of health. The goals of the Improve initiative are to prevent maternal mortality, which shows major health disparities, also to decrease severe maternal morbidity, and importantly, to promote health equity. Because of the timing of the budget this year, what we've decided to do this year is to have 3 very strong pillars that will roll into the Centers of Excellence. The Centers of Excellence funding opportunity announcement will come out this summer. In the meantime, we have a major goal of increasing community partnerships. And in particular, we want to bring in communities that have knowledge of the local culture and have a trusted relationship. Trust has come up today as well. And so we need people who have a trusted relationship in the community to begin to implement changes that will result in improved maternal care. The other thing that we're doing is we are developing technologies that will particularly improve care for women who are in underserved areas, the so-called maternity deserts, as well as women in rural environments who don't have access to obstetric care. So we're looking at wearables, we are looking at apps on your cell phone as ways that we can monitor women who are in trouble and who need to get appropriate care. As far as the Office of Women's Research on Women's Health, I think Dr. Tabak will answer that.
So the additional resources to ORWH, which we are very thankful for, they will invest that in their so-called Birch program, which I think you're familiar with. This is an interdisciplinary program which provides mentorship to the participants. It connects the junior faculty, they're known as Birch Scholars, to senior faculty who have a shared interest in women's health. And this is really a program that is key to supporting multiple goals of the NIH-wide strategic plan for women's health research.
I'm well over my time. I have another question, which I'm going to try to squeeze in, not now, but later, on cancer immunotherapy. Congressman Cole.
Thank you, Madam Chair. I couldn't help but reflect my good friend from Massachusetts when she made her pitch for ARPA-H. I thought, well, I could help on that if the Patriots can come to Oklahoma City. I mean, we could work something out here. That's probably a private conversation. But I do have two serious questions, and I'll try and ask them both. One will be for you, Dr. Tabak. One, Dr. Volko, will be for you, and you can just split the time. And this first one will probably be better directed to Dr. Hodes, but he's not here. So I'm very curious on the Alzheimer's front. We've made considerable investments. We've had a lot of concern about just the sheer expense this disease imposes on us, not to mention the human tragedy. So how do you see the state of play? Obviously, we've had some controversy over a drug. Personally, I'll just state for the record, I don't care about the cost. I care whether it works. Over time, we can bring the cost down if it works. I know that's not your decision to make, but any thoughts you have in that area? And Dr. Volko, just to give you sort of a heads up, what I wanted to get from you, I'm very curious about your thoughts on marijuana use. Just given the prevalence we have now, it looks to me like honestly, the social use has outrun the science. I mean, we really don't know, and to my way of thinking, the potential damage here, and you know, the horse is already out of the barn probably, but I'm curious about where you see the problem areas here, where the research is taking it. So with that, if I may, Dr. Tabak, let me go to you first on Alzheimer's.
So just top line, we're funding more than 350 trials in this space now. 70 are pharmacologic treatment and prevention trials. 120 are non-pharmacological and prevention trials. And then the remainder are related to dementia care and caregiving intervention tools. Very important, obviously. Public-private partnership, AMP-AD, has identified over 550 new drug targets. The Impact Collaboratory is developing pragmatic trial infrastructure to really look at how we improve care for these patients. And I'm sensitive to the time, so let me turn to Dr. Volko.
And thanks very much for the question. And indeed, the use of marijuana has gone up, particularly among those that are 18 years of age or older. And during the COVID pandemic, we have seen, again, this has increased. And among the areas that we are most concerned, of course, are pregnant women. And we've seen during the COVID pandemic a significant rise in the utilization of marijuana, whether it is for medical, the so-called medical purposes, or recreational use. All along, we've also been very concerned about the consequences of marijuana use among particularly the developing brain. And that actually goes starting in fetal development towards childhood and adolescence. And the data already shows that the outcomes are much worse for women that smoke marijuana during pregnancy. And the data also shows that use of marijuana in teenage years actually significantly impairs the performance of these teenagers at school. But what is also worrisome is we have seen that significant increases in acute psychosis associated with the use of marijuana across all ages. This is in part driven by the fact that the currently available marijuana has higher content THC, so it's much more powerful. This is also associated with higher risk for accidents. There are other areas that are not clear, but the numbers seem to suggest that there is an increased risk, for example, on suicidal behavior among people that are using marijuana regularly. The extent to which they are using marijuana to escape suicidal thinking as opposed to having causality association is unclear. But we are prioritizing these areas because the American public deserves to know, ultimately, if they are going to be making a decision of taking marijuana for medical or non-medical purposes, what are the potential consequences? And we as a government, of course, need to identify what are potential adverse effects so we can put resources and do prevention interventions and therapeutic to support those that become victims of its effects.
I would just urge you to do what you can, the time I have left, to get as much information out as quickly. I think we're going to wake up someday and find out this is a lot like tobacco. We understood a lot more about it too late, and we've then reacted legislatively over the years at the state level and the federal level to try and deal with that. And we could have the same thing here. I would ask this, Dr. Tabak, you, again, I'm not going to ask you to respond, but maybe Dr. Hodes could follow up. I'm very interested in whether or not, Dr. Collins told me one time we thought the investments we had made might bend the curve looking forward in the cost of care and this particular disease with Alzheimer's. And so I'd love to know if we're making the kind of progress I know that Dr. Lowy and his folks at the National Cancer Institute have been making on that, or that's foreseeable.
We'll certainly follow up with you.
Thank you, Matt. Yield back, Madam Chair.
Congresswoman Roybal-Alley.
Well, Congressman Cole actually asked the question that I was going to ask with regards to marijuana. And I just want to add to what was already said, that according to the National Poison Data System, they identified a rise in marijuana use in children 0 to 6 years old, with over 70% of those cases in states that legalize recreational use. And that's just a number based on those that have come to hospitals for emergency treatments. So there is, I share the Congressman's concern on the fact that with the legalization of marijuana, there's also a decrease in the perceived harmfulness of it. And so I appreciate the research that you are doing, and I hope that at some point, as Congress considers legalizing it across the nation, that you can give us some guidance on safeguards and that could be put into that legislation, if in fact that does happen. I want to follow up on a question that was asked by Congresswoman Herrera Butler with regards to fentanyl. Several states have adapted preventive tools such as fentanyl test strips into their overdose prevention strategies. And as you are aware, approximately half of states continue to oppose the implementation and decriminalization of fentanyl test devices. What does Nita research tell us about the effects of decriminalizing fentanyl test strips on opioid overdose? For example, is there a difference in the drug overdose deaths across states that have criminalized fentanyl test strips versus those that have not?
And that is an important scientific question, and actually one that we will look into. Currently, we do not have that data, but we can clearly tell you from the epidemiological studies that have actually reported that a significant number of overdose deaths from individuals that are taking drugs like cocaine and methamphetamine that are contaminated with fentanyl was unbeknownst to the user. So providing them with a tool that enables them to actually test the drugs that they are buying to see if they have or not fentanyl could significantly decrease the risk of overdosing.
Dr. Tabak and Bianchi, on December 2014, the congressionally directed National Children's Study was terminated, despite ongoing congressional concerns that this study was critical to assess the impact of environmental risks upon children's health and development. To address congressional discomfort with the NIH decision, former Director Francis Collins instituted the Environmental Influence on Child Health Outcomes, known as the ECHO program. As you know, the ECHO program made use of existing maternal pediatric cohorts, which were recruited through the National Children's Study to address the 5 health outcomes of pregnancy and birth, upper and lower airway conditions, obesity, neurodevelopment, and positive health. And we are currently in the final year of the 7-year program. And before I retire from Congress this year, I would like to have some assurance that the ECHO program has either met most of the goals of the original congressionally directed study, or that there is a plan in place to continue and build on the ECHO research thus far. Since the inception, can you highlight some of ECHO's key accomplishments with respect to its observational and interventional research component, and what approaches has the ECHO program taken to ensure that its research findings are widely disseminated amongst participants, policymakers, and other stakeholders?
So there are a number of high-impact findings that I could share with you. ECHO is the first to show disparities in asthma incident rates across the United States by racial and ethnic populations in early childhood. Obviously, this might lead to solutions to address the health disparities. We spoke earlier about particulate matter in the air. ECHO has found that ultrafine particles late in pregnancy are associated with the development of asthma in the first years of life. And this obviously has the potential to inform regulation of these ultrafine particles, which are not currently regulated by the EPA. Finally, there's an obesity study of over 37,000 babies and young children from the 70 ECHO cohorts. The obesity rates were higher among the older than younger children. The rates are higher in non-white races and ethnicities. Going forward, they are expanding to include 20,000 additional women recruited during their pregnancy, and they've included a preconception pilot of 10,000 couples, which they estimate would result in about 3,000 births. So that ultimately will allow you to understand questions about health disparities and health equity, social determinants of health, as well as natural experiments or health crises as you follow these individuals longitudinally.
My time is just about, but I just want to know, is there any plan to extend the ECHO program beyond the 2023?
We certainly will be asking for additional support. Yes.
Okay, thank you.
Congressman Harris.
Thank you very much. Glad we had a lightning round here. Dr. Lowy, listen, I want to thank the NCI for actually issuing a notice of special interest to promote research and understanding the mechanisms by which cannabis and cannabinoids can affect cancer biology, cancer interception, cancer treatment and resistance, management of cancer symptoms, et cetera. Dr. Volkow, is this ready, shoot, aim? I mean, we're basically approving a medicine because, as you said, so-called medical marijuana around the country without having done these studies yet. We don't know what the effect on tumors are of widespread marijuana use. This is a rhetorical question. It's kind of a bad idea, isn't it? Shouldn't we know the questions to whether testicular cancer, for instance, is the incidence is increased by marijuana before we actually legalize it everywhere? A rhetorical question. You don't.
Yeah, this is why we do research.
That's right. Thank you very much. Dr. Tabak, in your notes, you noticed that in your testimony that the nutrition research is going to be kind of overseen by the Office of the Director. Do you think it would be worthwhile to study whether SNAP purchases should be limited to the WIC nutrition-based food list in order to deal with the problems with obesity, diabetes, things like that? Do you think that would be a worthwhile thing to look at?
It's certainly something to look at.
I think it's about time we do that. We know from the COVID pandemic that obesity is a real problem in America. It leads to serious morbidities and mortalities. And yet, as a government, through SNAP program, we kind of encourage obesity by allowing the purchase of things like soda and chips and things like this. Dr. Tabak, also, because we talked about Alzheimer's research. I know that the Institute of Aging did not directly fund the Aduhelm research, but the FDA decision, and again, the firing of the CEO, of the company, the FDA decision to take the particular track they have toward payment for it, do you think that's going to have a relatively chilling effect on privately funded Alzheimer's research going into the future?
Well, this is something that NIH has no authority over.
Well, I know, but NIH obviously cares about the broad spectrum of Alzheimer's research, both NIH funded directly and the fact that the private sector is an important R&D sector. Does it give you a little heartburn that there might be a pullback on privately funded research due to that CMS decision?
Partnerships with industry are very important to moving our agenda forward.
Yeah, that's what I imagine. And just one brief last question, Dr. Fauci. Ad maiorem Dei gloriam, not everyone's going to know what that refers to, but you and I do know what that refers to. You're respected as kind of a scientific voice for the country. Does the physical and genetic life of a human being begin at conception? Does the physical and genetic life of a human being, not a human person, a human being, begin at conception?
I don't know if
I will, you can do it as a QFR if you want. You can respond to that, but I will ask that question as a follow-up. I yield back, Madam Chair.
Mr. Pocan.
Thank you, Madam Chair, and thanks for the second round. I also want to thank Dr. Volkow for the work at NIDA that you've been doing around research around kratom. I think, the vast majority of states, it's legal. My state, it's not in Wisconsin, and I've worked with Republicans and Democrats to try to change that. But I think even the way you describe it on your website, you've always been an advocate for additional research. We know that it's helped many people to get off of opioids. Unfortunately, we're in the tens of millions of people there, but there are thousands and thousands of people who this has worked for quite well. And I just wanted to say thank you. You don't even have to answer a question on it. I just wanted to make sure I acknowledge the work that you're doing. I do want to ask Dr. Tabak a question. So you're a dentist in addition to being a scientist. And I know that healthcare providers often take the Hippocratic Oath or a similar commitment to medical ethics. Do pharmaceutical companies have a similar obligation to prioritize the well-being of the patients they serve, even if it means putting the greater good ahead of their own profits?
I'm not aware of what their standards are.
Would you think that would be a good standard?
Of course.
Of course. Could you say that again?
Yes, of course.
Thank you. Okay, I just want to make sure I had that. And the reason I asked that, and I think I got a little ahead of myself, and Dr. Fauci, I had to answer the other question on all the money that NIH is providing to the promising next generation pan-coronavirus vaccines, is really a question currently with a drug, and I'm probably going to kill the name because they do that to us, Xtandi, if I'm saying it correct. So, right now, this is a prostate cancer medicine marketed in the U.S. by a subsidiary of a Japanese pharmaceutical company, Astellas. They charge U.S. taxpayers and consumers 2 to 4 times the price of that than in other countries, despite U.S. taxpayers having funded the invention of this through NIH. Now, this question is simple, real first one. Has it changed in the last decade? No drug approved by the FDA has not had NIH investment. Is there a drug yet that's approved by the FDA in the recent memory that's not had NIH investment?
Not to my knowledge.
So specifically to this drug, where honestly price gouging, we're getting ripped off right and left, in my opinion, by pharmaceutical companies in so many cases. This drug in particular, under the Bayh-Dole Act, when the U.S. government and taxpayers funded invention, we have rights to that invention, including the right to market and license competition when U.S. taxpayers are price gouged. You've gotten a letter from a number of elected officials on this drug, but this is just one of many that I think we could point out and have a long conversation on. Will you step in as NIH and be responsible stewards of the medical and pharmaceutical inventions it uses tax dollars to help develop, ensuring that taxpayers aren't being forced to pay twice, once on the front end through NIH and then once again through these higher prices more than other people in the world? Are you willing to start seriously looking at doing marching in rights on these types of drugs?
So as you know, it's a complex space. And up until now, neither NIH nor other agencies that have looked at this have thought that price per se met the criteria that are needed for margin, which depend more on the availability of a drug. So for example, if there are no manufacturing plants that are available to manufacture a drug, that would be an example of perhaps where margin would be used. In this case, the barrier is strictly a financial one. We are just as concerned about high prices as any other person or agency, but we need to ensure that we're using the right tool for the right job. The request that you refer to is under consideration, and we are looking at it both specifically and in the context of the broader plan that the department has for lowering drug prices.
Yeah, I just hope we consider this. I sat down with someone recently who every year I meet with on his particular ailment, and his health is going down and down. And recently there was a drug that he told me he was considering passing up that was $50,000 he had to do twice a year for his health. And I've watched his condition, and I just think it's time. This is something that, again, I think back in the future, we'll look back why we didn't address this, and I think we've had the tools to, and if you need additional tools, please let some of us know. We'd love to give you those tools. Very quick, in 18 seconds, if possible, Dr. Lowy,
I know the Cancer Moonshot, we're getting additional dollars, and that's great. How about some of the smaller cancers, things like NET, the neuroendocrine tumor of the pancreas, those sorts of things? Are they also going to be able to see a good chunk of that money and the help on that money?
Well, rare cancers are, of course, very important. They represent about 20% of cancer, and the people who get them is just as serious as common cancers. So we, of course, thanks to the generosity of your committee, are in a position where we can study rare cancers. In addition, we can look at potential interactions, if you will, where findings in one kind of cancer might have implications for another, and very importantly, conducting clinical trials. So people with rare cancers, certainly all of our childhood cancer treatment and those trials involve are rare cancers. And then many of our trials really now are eligible for people who have particular molecular abnormalities. They are multi-arm trials, and so there are many people with rare cancers who are eligible for those. Thank you very much.
No, thank you, and thank you for the extra time. I appreciate it, Madam Chair.
Congressman Fleischman.
Thank you again, Madam Chair, and this has been really a truly outstanding hearing, so substantive. Point of privilege, Dr. Lowy, thank you again for all you're doing to combat cancer. I think this is something, I'm part of the Cancer Caucus, lost both parents to cancer, one when I was very young, but this is something that I think really our investments with you all are really proving to be great. I keep up with my good friend Dr. Jordan Berlin at Vanderbilt. Sometimes we'll just pick up the phone and start talking about stomach cancer, other different types of cancer, and the research is just truly incredible, as are the results. So keep up the good fight, sir. Thank you. If I may, on a different topic, organ transplant shortages. There's an unfortunate and overwhelming shortage of health organs in this country. Statistics show that over 100,000 men, women, and children are currently on the national transplant waiting list. Our traditional cadaveric organ donation process has become increasingly inadequate to meet the needs. Question for Dr. Tabak and Dr. Gibbons, if I may. Given the recent efforts in xenotransplantation, does the NIH have any plans to develop protocols and research into this area, given the shortage of organs readily available for patients in need?
Well, let me turn to Dr. Gibbons, the specifics.
Certainly, from a standpoint of the National Heart, Lung, and Blood Institute, this is an area that has been investigated pretty much for decades, and certainly there have been some progress made, particularly related to newer technologies, even genetic engineering, gene editing technologies that are making, at least on the horizon, that there may be some feasibility here. However, I think we do need to be sure that the zeal of which this is being implemented is done in keeping with that science. And so it's quite clear that there still needs to be a lot more work done before this is really translating into clinical practice, and still some major issues that may need to be addressed with regard to still acute rejection and what have you. Perhaps Dr. Fauci may want to comment on this as well. But this is an area that, as I say, has been on the horizon for many years. There's some opportunities for progress, but it's still early days.
Thank you, Dr. Gibbons. And yes, I'm solicitous of anyone who'd like to answer the question.
Well, I don't know if I could add much more than what Dr. Gibbons said, except that there are a lot of problems with xenotransplantation. I think we just recently had the experience of the transplant of a pig heart in an individual, and what happened was that there was a pig virus in the organ that was transplanted, and it was very likely that with the immunosuppression following the transplantation that you reactivated a cytomegalovirus from the pig, which might have actually caused the death of the individual. So it's a very important goal because of the reasons that you delineated in your question about the shortage that we have. And it's an area that continues to, as Dr. Gibbons mentioned, perhaps a lot more understanding about gene editing of the particular xeno that is going to be transplanted might actually make it much better. But there's a lot of work that needs to be done.
Thank you, Doctor. Madam Chair, I'll yield back. Thank you.
Ms. Herrera Butler.
Thank you, Madam Chair. And actually, I had not seen the end of that story. I knew that that transplantation had taken place and was watching it with great interest. Let this be a reminder that when it comes to certain organs, like the one this gentleman needed, or other organs, donation, both deceased and living, donation remains a really viable option, and not enough of us do it, and there are a lot of people waiting. So that was my point of personal privilege. On the maternal and child front, I was thinking I was going to ask Dr. Bianchi, but I think I'm going to ask Dr. Tabak, and it's with regards to ARPA-H. I wanted to know if ARPA-H will be providing funding for pediatric research, and just kind of ask for that commitment that it not be left behind.
Well, obviously, we don't know what ARPA-H will be funding yet. That will really be driven by the inaugural director and the program managers that he or she hires.
And the members of Congress that bird dog that new director.
And
with regard to pediatric research.
And certainly, I can't imagine that we would let children behind.
Thank you. I appreciate that. Now to Dr. Bianchi. I wanted to quick follow-up on research with regard to stillbirth. And do we know more about this? Are we able to treat this better?
Thank you for your question. And just for those people who don't know, stillbirth refers to a spontaneous death of the fetus after 20 weeks in the womb. And it's a tragedy, and it's something that we still don't know a lot about. What we do know is about 20% of the stillbirths are caused by an extra chromosome. Presumably, there are some additional genetic causes that involve only one gene or a cluster of genes. And one of the things that we have funded in the past year in conjunction with the Human Genome Institute is an expert curation panel on gene mutations as a cause of stillbirth. So we know how to sequence the genome. We know that in the past year, there's been tremendous progress in the sequencing of the human genome. But what you need to know is how to interpret that information. So we are funding an expert panel of computer scientists, maternal fetal medicine specialists, geneticists, et cetera, to look at these mutations and then determine which ones of them may be associated with stillbirth. But adverse outcomes of pregnancy are very, very high priority for our institute and preventing those adverse outcomes.
Appreciate that. I wanted to talk, excuse me, with Dr. Volkov about research with regard to drug use. Washington State, in practically speaking, you can do drugs, just about anything, in front of an officer. You still can't technically sell drugs over a certain amount, but it's pretty, they call it the Wild West for a reason. And my big concern, a number of years ago, we legalized recreational marijuana use, and the data on that is rolling in, and it's not promising. But when you add to it any type of substance, I'm curious whether or not you all are following the different states with regard to these I don't know, lax regulations, I don't even know how to talk about it. But essentially, some states allow you to do this. Are you following the population trends in these states?
Yes, absolutely. I think it is a unique opportunity that we have to understand how the different policies implemented by the states affect the outcomes in children, adolescents, and adults. And in this case, we know, for example, that the policy implementation as it relates to cannabis has significantly impacted the adverse effects of cannabis utilization. So we expect that, unfortunately, similar trends may start to emerge as other drugs by other states are legalized.
Well, and I think one of the things we were talking about fentanyl and overdose deaths and those increasing. This isn't a one, there's multi-legs to this stool in terms of the problem. There's certainly, homelessness and a challenge in that front, affording a home in my area. But that's different from, drug legalization and how we approach people who have substance use disorder. And that's different from, I think, the predatory nature of, gangs who bring drugs up from Mexico and make their own pills, and those pills, and then we've got children who've come through the pandemic and are dealing with mental health challenges, and their friend says, here, I got a pill for, however much money, you can take it, and it's laced with fentanyl, and we lose that young person. Those are all happening right now. But I think the one thing we have a little control over is at least getting the data. And I'm very, very hopeful that your look at this is going to provide information for lawmakers as we move forward.
We need to do it because we need to identify what areas are challenging and how to intervene about it. And this is the way that we're right now, for example, monitoring the increased overdose deaths that we're seeing in teenagers. And these overdose deaths are likely to be driven, as I mentioned before, by the contamination of illicitly prescription drugs, manufactured drugs, by fentanyl. So it's not teenagers looking for heroin or fentanyl. Mm-hmm. It's teenagers not knowing that they purchased an Adderall pill or a Vicodin that contains fentanyl, and then they overdose.
Yep. Thank you, Madam Chair.
Congressman Molinar.
Thank you, Madam Chair. Dr. Fauci, I wanted to ask your insights on when we will no longer call the current COVID public health emergency a pandemic. Are there criteria? Are there benchmarks? What kind of a process will we go through to make that determination?
No, there is really no firm, widely acceptable definition. When one talks about pandemic, you talk about a highly transmissible infection that is essentially widely distributed throughout the globe. I've spoken about this recently. When you're in the acute fulminant stage of pandemic, the way we were in the United States just a few months ago, you might remember we had 900,000 cases a day, tens of thousands of hospitalizations, and we were averaging 3,000 deaths a day. That's a really highly fulminant stage of a pandemic. We're come down to a low level. Now we're unfortunately ticking up a bit. But when you get down to a level where it isn't disrupting society, it isn't causing deaths that stress your hospital system, and you have a level of infection that, for example, might be comparable to what you see with respiratory syncytial virus or parainfluenza, even though it's prevalent throughout, it wouldn't be considered a pandemic in the classic sense. But there's a lot of gray zone about the definition. So I don't think you're going to see all of a sudden one day there's going to be a declaration that the pandemic is over. It will likely be that it is no longer in the pandemic phase and it's more of an endemic kind of infection that you could live with. Right now, we're not there. I mean, if anybody asks that question, that's for sure.
And then from the public health emergency and the legal definitions in states and throughout the country, where do we stand with that, given the sort of the open-ended nature of that?
Yeah, I'm not sure I can answer that with any authority, Congressman, because that's not essentially what we do here at the NIH. But there will be a time, obviously, when an examination of the level of infection and the level of impact in the country will then dictate whether or not it's pulled back as an emergency. But I don't think I can be able to give you a really good answer on that.
Okay, thank you. And then on the vaccines for COVID, I think people are weary of, this for the last couple of years. They've followed the recommendations of vaccines, boosters, but I think there's a certain weariness in the American public. What is your sense and recommendation going forward with respect to vaccinations, what a definition of fully vaccinated would be?
Yeah, well, it's very clear right now, if you look at the need for vaccination. I mean, if you look at the hospitalizations and the deaths of those who are unvaccinated compared to those who are vaccinated and boosted, the data are stunning. They're striking the difference. That's point number one. But I think the question you're asking, in the era of Omicron, it's very clear that a boost is needed, a third shot. If you look at both the durability of protection, there's no doubt, not only to natural infection from which you recover, but also from vaccination. Over a period of time, there's a waning of immunity. And the data, and other countries like Israel have really good data that when you get X number of months out, even from the third shot, you then get an increased risk, particularly among the elderly and particularly among those with underlying conditions of hospitalizations and death. So right now we're in a situation, as you recall, that the FDA and the CDC have said that people 50 years of age or older are eligible for a fourth shot of an mRNA vaccine, not only the third boost, but the fourth shot. Right now, the advisory committee to the FDA met and are looking at what the recommendations are going to be as we get to the fall, namely what's going to happen when we get to September and October. It is very likely that all of us who've been vaccinated will have a diminution of the level of protection after a certain number of months, and it is likely that they will be recommended for everyone to get a boost then, and then it will be determined, does that got to be every year the way we do with flu? And we don't know that right now because of the fact that we're having different variants. But right now we're in an Omicron era, and the vaccines that we all got work pretty well so long as you do get a boost. I think sometime in the middle of the summer, we're going to know what the cadence is going to be about how often we're going to have to vaccinate people.
Okay, thank you. Madam Chair, I yield back.
Thank you. With that, let me turn to my ranking member and my colleague here for any closing remarks.
Thank you very much, Madam Chair, and I want to thank all of you, frankly, for not only being here and being so generous with your time, but for what each and every one of you do. I am a huge believer in what's been done at the NIH, and as I said in my opening remarks, it's one of the things that the chair and I share in common, and it's been one of the things, honestly, that's made it easier for us to get to contentious issues. When we disagree about something, we say, well, let's just spend the extra money to the NIH. I mean, we agree on that. So you've been the beneficiaries of stalemates in other areas, perhaps, but the work that goes on is really extraordinarily important. And the one pledge I'll make to each of you and to my good friend, the chair, is we're going to try to continue to do what we've been doing since 2015, and that is make sure that you have resources above the rate of inflation to continue to expand your mission. I do, as I said, Madam Chair, share your concerns, have concerns of my own about the ambitious funding of ARPA-H in the President's budget, simply because I think that may come, but I think it's a little bit soon, in my opinion, for us to do that now until we have a better sense of the structure and honestly resolve some questions that some of our colleagues on other committees have or differences. And again, this is not a partisan issue. I find a wide spectrum of opinions in each party as to how to structure this, where it should go, what the appropriate level of funding is. So at least for me personally, we're just not prepared to make that big an investment, and particularly if it comes at the cost of being able to continue the regular and steady increases that we've had for 7 or 8 years at NIH. I think that's been a good course for the country. I think it's paid off. I think you've used the resources well, and I'm grateful for that. I'm also particularly grateful for the role that the NIH and I think some of the things this subcommittee did pre-pandemic, how it positioned all of you and to help the country during a COVID crisis. I still always point out to my constituents at home what an enormous difference it made to have 3 vaccines in 10 months and what an extraordinary accomplishment that was, and it was a public-private partnership. But if the resources aren't there early, and often you don't have the resources, you don't have the labs, you don't have the researchers, you have to, to my friend Mr. Pocan's point, you have to think about this as part of national defense, a point that I've made plenty of time. We've lost 1 million Americans in a year or 18 months or so. That's an extraordinary thing. But it would have been a lot more had the investments not been made early and we not had the exceptional capabilities that we have at NIH and through our biomedical research community and had we not mobilized and dealt with this. And this won't be the last one we see. We know the biosphere will continue to throw things at us. and we have to have this capability at all times. So I want to particularly end by thanking my good friend, the chair. She's been a wonderful advocate for the NIH long before I was in Congress, and on this committee has played an important role from when she first arrived at the furthest distant chair to now her pinnacle, not only as the chair of this very important subcommittee, but more importantly, as the chair of the entire committee. And that has been an advantage, I think, for folks engaged in biomedical research, because she's been a tireless advocate, and she's in a position not only within this committee, but the entire committee to do that. And I'd also be remiss not to tip my hat to our friends on the other side of the rotunda, Senator Murray and Senator Blunt, who also have been extraordinary advocates. I think we've had an unusual collection of, four folks that all wanted to move in the same direction. And again, hasn't mattered very much who was the president or which party happened to be in power at a given time. And I think that's a tribute to all of you and the work that you do, that you can unite us in that way. And that really does need to continue going forward, because I think this is an indispensable national priority that I think we just got a serious lesson how important these investments are and need to continue to be. Last point, again, you can't just do it at the chair and the ranking member level. You got to have a lot of members that are interested in doing this too, and we do on both sides of the aisle. So we're going to try to continue down that course, continue to make the resources available to you, do what we're required to do in terms of asking tough questions or holding you accountable. But again, I think, there's lots of critics, but I'll just go back and look at what was done over the last 2 years and the speed with which it happened and the lives that were saved, I think, is a consequence of what you did, not to mention all the other things that happen to be going on out there simultaneously. It's not like you stop everything in cancer research or Alzheimer's or whatever. Those are important missions, and they go on as well. But to mobilize the way you did, again, in cooperation with the broader biomedical research community, public and private alike, is something that I hope you regard as with a great deal of personal pride, because, again, you all deserve it, and you all are dealing with the ramifications of this awful pandemic and everything from mental health to depression to drug addiction. It's, the consequences of this thing, which our chair has looked at through a series of really good hearings, have put a lot of stress and strain on what we need to do. So, Madam Chair, thank you for your leadership in this, and I look forward to continue to working with you. Yield back.
Thank you so much, and thanks to the ranking member. I think we are both so really proud of the support that we've been able to really, to reach out and get. And as the ranking member said, there are, just not on this committee and just not on the House side, on the Senate side, there really is, such an interest in our looking at the discovery to cure, and which is what you are engaged in on a daily basis, and what we've been able to provide for NIH research. The $15 billion, almost 50%, over the past 7 years. Really very proud of that. And it's also why we speak about critical to strike a balance, and to continue to support, important research really in all areas. And the concept of ARPA-H is very, very exciting. It needs to get lifted off the ground. We've started in that direction, but we need to get a sense and, again, create that balance and not leave behind areas of research that we need to try to be pursuing. I'm very serious about wanting to review funding across the institutes and the centers, what that's been over time, because I want to see that we are creating opportunities across the 27, institutes, so that each of the areas is rising to its potential and what we can do to alleviate, you know, some of the pain associated with illnesses or diseases that, you know, don't rise, you know, to that top level. And Dr. Tabak, given what you said, if there were more research in some of these areas, they could then be in that category where it is time to move because of the discoveries that have been made. I thank you, and we appreciate so much everything that you do to deal with scientific breakthrough. And the reason why we're so concerned around this is because of the outcome. You save lives, and you protect families, and that requires sustained investment over time. So we'll look at that balanced effort. There are two or three things that I just wanted to mention. And there's been a kind of a conversation. I go back to what I said. I think that we were able to move as quickly as we did on COVID was because of the years of investment in research. And it allowed us to spring forward when this horrific pandemic, was upon us. And I get annoyed when I see, pharmaceutical companies who won't recognize the work of NIH scientists who were instrumental in moving forward. We know the power and the strength of the NIH. And it is, that is something that we really need to think through of. This is taxpayer research. And we are so deeply invested and want to continue to be deeply invested, that to think about areas of cure where people can't get access to it because it's priced out of the market. They can't get access. My family could afford what I needed for ovarian cancer. Not every family can do that. That doesn't mean that women should die because they just don't have the financial wherewithal, especially when we see an industry which is just making money hands over fist. If there's some talk about balance, we need to do that. We need to be able to negotiate price. We need to be established, some parameters around where we need to go and bring down the cost so that people can afford to survive. So this is, I also just want to say, and I would like to hear your voices, not now, obviously we're well over time here today, but the pandemic is still with us. It's with us here, and it's with us overseas. And I view us as having a moral obligation for us to have a COVID supplemental bill, which allows us to continue to provide the vaccines and the treatment that people need here. And we have an obligation to make sure that we are looking at what you said, Dr. Fauci, is we have the doses, but the delivery system of getting the shots into arms and creating an opportunity for those countries who can do it to be involved in the manufacture. Doesn't have to be, those patents don't have to be on a permanent basis, but by God, they should be there now and allowing people to be able to survive. We are not safe unless we do something about curtailing the effort overseas. I did say to you, Dr. Lowy, and I'm going to submit the question because immunotherapies are there, but they work, they don't work. There's the correlative studies. Would love to get your view of how that's being used and how we can move forward. I'm just going to make this last statement. For the record, it's clear that the leaked Supreme Court decision that would overturn Roe will have an effect, negative I believe, on maternal mortality. And I believe that women will be harmed by this decision. I think that that's something that we need to take a look at, that we need to examine in a scientific way, and not on the basis of politics or ideology, but we need to understand what that means to women's health. For all that you do every day, and we are so grateful, and please understand, I think that this is a committee that wants to see you be able to think outside of the box, take your talent, and make sure that we are finding that discovery to cure. Thank you. And with that, this hearing is adjourned. Thanks so much.